to introduce our Japanese guidelines in English, so I will try. As you know, Japan is the next country to Korea, and we are good friends. And I'm from Hokkaido University, and Hokkaido is a North Island located in the very north part in Japan. So when we talked about our Japanese guidelines, we have to know characteristics of Japanese COPD patients. And that's good examples, good papers, comparing the directly between the Japanese cohort and general total cohort of in the large-scale clinical trials, uplifts to net. And when you look at the gender and age and BMI, actually Japanese patients are almost more than 90% COPD patients are male, and age was 3 to 5 years older, and BMI is 4 to 5 less compared to the overall almost the Western population. So I think these characteristics are very similar to Korean COPD patients, I think. So we have COPD guidelines by the JRS, Japanese Respiratory Society. Actually, the 5th edition published last year. You can read COPD in 2018. I'm sorry, I can say only Japanese version available, so we don't have English version and as well as Korean version, sorry. And actually, very characteristic thing is we have another guidelines for overlap of asthma and COPD. And actually, the first edition was published last year, so ACO in 2018. I'm sorry, again, only Japanese version is available. So I'd like to introduce the content of our Japanese guidelines. So speaking of definition of COPD, COPD is a disease of the lung that is caused by long-term inhalation exposure to noxious substances such as tobacco smoke, and characterized by airflow limitation by prominent PFT. And the airflow limitation is attributable to the complex effect of the peripheral airway regions and as well as emphysematous regions. And clinically, COPD is characterized by exertional dyspnea and chronic cough and sputum production, but some patients do not have these symptoms. So I think the very important and characteristic things I colored as red. And to summarize, in JRS guidelines, we emphasize tobacco smoking as a cause because in Japan, actually the air pollution level is low and biomass exposure is pretty low. So we have to emphasize tobacco smoking as a cause. And as well as we emphasize small airway disease as well as emphysema. You may know that the Japanese physicians easily take CT scan. We cannot, actually we don't care cost. So many Japanese physicians think COPD equal emphysema, but that's not wrong. So we have to focus on the small importance of small airway disease. And actually, JRS guidelines touch on less symptomatic patients. I will talk about this later. And diagnostic criteria of COPD, I think that very similar or the same as gold and Korean guidelines. Number one, exposure risk factors such as tobacco smoking. And very important thing, number two, FEV1 over FVC ratio less than 70% after bronchodilator administration, and rule out the possibility of other diseases. So this is very the same as international or Korean guidelines. And we have goals of COPD management. And number one is the improvement of the present condition by improvement of symptoms and QOL, and improvement and maintenance of exercise tolerance and physical activity. And by doing that, the number two goal is reduction of the future risks, the prevention of exacerbation, and prevention, diagnosis, and treatment of systemic comorbidities and pulmonary comorbidities. To achieve this, we have a strategy of management of stable COPD, actually very simple way. I'm sorry, we don't apply gold ABCD assessment, nor Ganada assessment even. So I just picked up the drug treatment from our management of COPD, stable COPD section. And actually of course we have severity of air fermentation from GOLD 1, stage 1, 2, 3, 4, the same GOLD criteria. But we can use lava or llama or lava llama even, relatively very fuzzy line there is, very fuzzy. So actually we can select, actually according to our health insurance system, when we diagnose the patient as COPD, we can use any drugs. So we can use at first alabama to relatively mild patients. Actually, in Japan, roflumilast is not approved in Japan, so we cannot use it. ICS should be used only in case of asthma overlap. Actually, this is the previous version of our management of COPD, stable COPD, and this here is the ICS treatment in case of repeated exacerbation. As previous speaker showed, actually the same comments in the previous Korean guideline. So ICS use in the management of stable COPD has changed from in case of repeated exacerbation to only in case of asthma overlap. So as I said, the GOLD ABC assessment is not adopted in our guidelines. I think there is several reasons. So the first, in the assessment of subjective symptoms, Japanese patients tend to express their symptoms differently. Just too shy, I'm not sure. Less symptomatic compared to the Westerners. And this is very important. The frequency of COPD exacerbation has been reported to be less in Japan compared to with other countries. So one of the reasons of this less exacerbations, we reported the data from our Hokkaido COPD cohort study, and we defined the exacerbation in several ways anyway. Please look at the absolute number of the, for example, this is moderate exacerbation, the prescription change, a very low number of the frequency rate, even in the goal 3. So when we compare this absolute rate of exacerbation frequency to the international large-scale clinical trials or clinical study, actually for example, GOLD 2 patient had only 0.14 exacerbation rate, and the same criteria, the GOLD 2 patient had 0.7 to 0.9 exacerbation rate in this study. So seems to be less exacerbation in Japan. But the question, COPD exacerbation is really less frequent in Japan. And last year, the very good review was published in the National Journal of COPD, but co-authored by my mentor, Professor Nishimura, and last author is Professor Paul Jones. And very good review, please read it. And actually, in this review, they identified Japanese 9 cohort studies and 5 randomized controlled trials. And these studies reported annual exacerbation rate from 0.1 to about 2 events per year. So actually, there is a big differences. So there's a large differences in the exacerbation reported rate in Japan. So actually, I think due to the settings of this study, design of the study, and inclusion criteria of the study, would be influenced with this large difference. But when we look at the data from Uplift, as I said in the beginning, we can compare the Japanese cohort and total cohort as well as Asian cohort, other Asian countries cohort. Direct comparison is, yes, less exacerbation rate in Japanese cohort compared to the total and other Asian countries cohort. So in general, COPD exacerbation seems to be less in Japan. There are several reasons. So in our country, patient can access very easily to medical care. If patient desired, they can come to the specialist directly, even at the university hospital. And variance in the morbidity profile, actually in Japanese patient, for example, the cardiovascular diseases are less, and environmental factors will be affected. And I think this is very important, diagnostic crossover with related disease. As I said, most of the Japanese physicians take CT scan very easily. So we can distinguish COPD from asthma very strictly. So this is seems to be important. And maybe one more important thing is underreporting of COPD exacerbation by Japanese patient. So let's move the topic to the ICS. So in the latest guideline, ICS should be used in the case of asthma overlap. So what is in the case of asthma overlap? And in this, another guideline for ACO, in this document, the criteria of diagnosis of ACO was set. And actually, at least one item from COPD and 2 items, or 1 item, 1, 2, 3, and 2 items of 4 from asthma. If patient have these 2 features, the patient will be diagnosed as ACO. So COPD feature is a smoking history, presence of emphysema and low diffusion capacity, and features asthma, so typical asthma symptoms and history of previous asthma diagnosis, and high FeNO and some other tests. So if patient have COPD features and only have high FeNO or high reversibility or high eosino, we can call the patient as ACO without typical symptoms or previous diagnosis of asthma. So I have a question, such patients really ACO? So in our cohort study, we tried to analyze the difference between the very typical COPD and COPD without asthmatic symptoms or without previous diagnosed asthma, but who have bronchial reversibility, eosinophilia, and atopy. So we defined these 3 things, but I will skip the detail, but anyway, we set these 3 asthma-like features. Importantly, in a cohort, subject with clinically diagnosed asthma were excluded. So as a result, half of patients did not have any 3 asthma-like features. In other words, half of patients have at least 1 asthma-like features, atopy, eosinophilia, or bronchial reversibility. And among them, some patients have multiple features of asthma-like features. And when we analyze the number of asthma-like features, so very interestingly, the number of asthma-like features increased, the annual change in FEV1 became slower. And when we look at the 10-year mortality, these patients who had 2 or more, 3 asthmatic features actually had better prognosis. So, and when we look at the association between the ICS use and the exacerbation or mortality, very interestingly, when we look at the exacerbation, patients who had ICS tend to be shorter time to first exacerbation, regardless of the number of asthmatic features. I think this is the reflection of the previous guidelines, because previous guidelines said that physicians should use the ICS for repeated exacerbation, and exacerbation has a repeated feature. So this data maybe reflected that fact. But very interestingly, that this black line and green line separated very largely when we look at the 10-year mortality. This green line is the best prognosis who had ICS and asthmatic features 2 or more. And this black line had worst prognosis who had ICS but asthmatic features 0 or 1. So such patients really echo. I'm not sure such patients we should or we must call them echo, but so may not be a worse phenotype, but ICS will be useful. So in summary, when we talk about the Japanese guidelines, well, we have to know characteristics of Japanese COPD patient, and very different from the Western countries, actually older, almost male and thinner and less exacerbations. And for some reason, Japanese COPD guidelines are very simple and do not adopt called ABCD assessment. And JRS also published the guidelines for ECHO, and I think the emphasis the importance of features of asthma in COPD patients as treatable traits for ICS. Thank you very much.
Thank you, Dr. Suzuki.